The cardiovascular system. Cardiovascular examination begins with the positioning of the patient at 45 degrees in bed and with the chest exposed.
I'd like to examine your heart, please. You mind taking off your shirt, friends? Thanks. Okay.
It is vital to stand back and make a general inspection, looking for dyspnea, cyanosis, an intravenous line, an ECG monitor, and so on. The detailed examination begins with the hands. Here the examiner is looking for clubbing, the stigmata of infective endocarditis, and for peripheral cyanosis.
Okay, thank you. Just relax there.
The pulse is assessed for its rate and rhythm.
And I'm also going to feel the pulse in the top of your thigh.
Radiofemoral delay may be relevant only if there's a history of hypertension. The blood pressure cuff should be 2/3 the size of the upper arm.
Just relax your arm for me.
Begin by estimating the systolic blood pressure by palpating the radial pulse. Then the diaphragm of the stethoscope is placed between the lower edge of the cuff and the brachial artery, and the cuff is pumped up again. The examination moves on to the face, where the eyes are inspected for scleral jaundice and the orbits for xanthelasma. Look at the conjunctivae for pallor. Loss of the normal contrast between the anterior erythematous conjunctiva and the posterior pearly white appearance is a reliable sign of anemia. Look for the malar flush of mitral stenosis and in the mouth for the high arched palate of Marfan syndrome and at the state of the teeth. Now the important cardiovascular signs found in the neck are assessed.
And relax your neck back.
Look carefully at the JVP and attempt to assess its character and height. The normal JVP can be seen to flicker twice during each cardiac cycle. Pressure over the upper abdomen for 15 seconds normally causes a transient rise in the JVP. A more sustained rise is a reliable sign of left or right ventricular failure, the abdomino-jugular reflux test. Next, the character of the carotid pulse is assessed. The examiner's attention now turns to the precordium.
Move your arm.
Look for scars, pacemakers, and chest deformity. The apex beat may be visible. The examiner now begins palpation of the chest. This usually starts with an attempt to feel the apex beat, establish its position, that is, where it is in relation to the midclavicular line and which interspace it is in, and to make an assessment of its character. It is worth spending some time on this important part of the examination. Palpation to the left of the sternum is performed to feel for a parasternal impulse. The hand then feels over towards the apex and at the base of the heart for the presence of a thrill, which is a palpable murmur. Auscultation is usually begun at the apex, with the bell of the stethoscope, and then with the diaphragm. The lower left sternal edge and the base of the heart are listened to in turn. If there is a systolic murmur, listen over the carotids to find out if it is conducted there or if there is a carotid bruit present. The mitral area is reassessed with the patient in the left lateral position. Here the tapping beat of mitral stenosis may be palpable, and the middle and late systolic murmur of mitral stenosis may be audible.
Thank you. Could you sit forward for me?
Feel the base of the heart when the patient is sitting up for the presence of a systolic thrill. In some cases, for example, if hypertrophic cardiomyopathy is suspected, dynamic auscultation may be indicated.
First to take a breath in and then breathe all the way out. Empty your lungs entirely. When I've got my stethoscope in place, to take a deep breath in, pinch your nose shut and then try to force the air out so as it pops your ears, okay? All right, go now. Hold it in, blow. Hold it. Okay, now breathe normally. Thank you.
The examiner asks the patient to lean forward and inspects the back for scars or deformity and for signs of edema over the sacrum. Percussion of the lower lung fields may reveal a pleural effusion, and auscultation, the inspiratory crackles that occur in patients with heart failure.
Take a deep breath in and out. Thank you.
The patient must now be laid flat so that the abdomen can be examined.
Comfortable like that?
The liver is felt with the right hand as the patient breathes in. A pulsatile liver is a reliable sign of tricuspid regurgitation. If endocarditis is suspected, the examiner should feel for the spleen. The examination concludes with an assessment of the legs. After compressing the skin over the lower tibia to test for pitting edema, the examiner feels the dorsalis pedis and posterior tibial pulses on each side. Compressing the calves for tenderness may be worthwhile if there is any clinical suspicion of deep venous thrombosis. The optic fundi should be examined if infective endocarditis is suspected. For the respiratory system examination, the patient should sit up in bed undressed to the waist. The general inspection should begin as the patient enters the room or begins undressing. The examiner stands back to look for signs of dyspnea, the rate and depth of respiration, and the use of the accessory muscles of respiration. Look at the bedside table for the presence of a sputum mug that may be conveniently placed for inspection.
Deep cough, please.
Ask the patient to cough and listen. The detailed examination begins with the hands. Look for clubbing, peripheral cyanosis, and tar staining. Squeeze the wrist to detect the tenderness of hypertrophic pulmonary osteoarthropathy.
Hands straight out like that for me, please. Okay. Is that tender when I press there? Okay, try this side. Any tenderness there? I'd like you to now spread your fingers apart and keep them apart while
Ask the patient to spread the fingers against resistance.
And this hand.
Weakness can be due to a brachial plexus involvement from a lung carcinoma.
Now to put your arms straight out and bend.
Then ask the patient to extend the wrists and straighten the arms. Watch for 20 or 30 seconds for the flapping tremor of carbon dioxide narcosis. Take the pulse for tachycardia, which will accompany respiratory failure or the use of bronchodilators. The irregular pulse of atrial fibrillation is common in patients with chronic lung disease.
Now just rest your head.
The examination now moves to the face. Press the maxillary sinus for tenderness.
And if I tap you there...
Look carefully at the pupils and eyelids for ptosis. One eyelid is lower than the other, and for the presence of a smaller pupil on that side. This usually means Horner's syndrome, which can be caused by an apical lung tumour. Look at the tongue and inside the mouth for central cyanosis.
Open your mouth.
If the patient's voice sounded hoarse, get him or her to say a few words. The examiner now has to decide if the trachea is midline or deviated to one side. It is important to be gentle and feel with the forefinger for the space on either side of the trachea. Deviation of the trachea to one side suggests upper lobe abnormalities, so it may be helpful to make this assessment at this stage. Most clinicians examine the back of the chest next. There are likely to be more signs of lung disease there. Sit the patient over the edge of the bed. Look at the shape of the chest and spine. Look for thoracotomy scars that may indicate previous lung surgery. The cervical lymph nodes are best examined from behind the patient. Some people find it easier to examine the supraclavicular nodes from this position. This is easy if the patient is sitting in a chair, but may otherwise mean climbing onto the bed behind the patient. From this position, upper lobe expansion can now be assessed.
Take a deep breath for me, please.
The clavicle should move up the same amount on each side as the patient breathes in.
And another one.
Lower lobe expansion is assessed by the examiners wrapping the hands around the base of the thorax. The thumbs are kept off the chest wall to allow them to move as the patient breathes in and out deeply. There should normally be at least 5 centimetres separation between them at full inspiration compared with full expiration. The examiner now flattens the hands on the chest wall to test for tactile fremitus. Compare the vibration felt on each side as the patient says 99, or for variety, 111. Now the examiner should percuss the back of the chest. It is important that the percussing finger, the plexor, is removed from the pleximeter immediately so that the percussion note is not damped. The examiner should remember the surface anatomy of the lobes of the lung while percussing. Remember to percuss in the supraclavicular fossa.
I'd like you to put your arms just a bit more in front. Thank you.
The same areas are now auscultated with the diaphragm of the stethoscope. Normal breath sounds are called vesicular.
And out. And keep doing that for me, please. Thank you, Richard. I'd now like you to say the word 99 when you feel the stethoscope against your back.
Vocal resonance is tested by listening with the stethoscope as the patient speaks.
Thank you.
Now get the patient back in bed. The examiner moves around to the front of the chest and stands back to make a general inspection for scars and for the small tattoos used as markers for radiotherapy fields. The skin may appear erythematous if the area has received a course of radiotherapy. The supraclavicular nodes are examined here, and this has not been done from behind. Expansion of the upper chest is best assessed by inspection. Percuss the anterior chest, percuss the clavicles directly. Auscultate.
Yeah. Again.